Hello all, welcome back to my channel. Today we are discussing how my exam went like. I've given MRCP part 1 in this August and some of the record questions. So the idea of record question is not to say that this is the right answer, because there are some questions which I don't know the answer for, but I have to put out the scenarios and how the overall exam experience and the questions were. So I'll put out the scenario, I'll give what were the options. If you know the answer to some questions that I don't know, you can comment down below. So let's get started. Coming to cardiology, first question in one paper was on cardiology, a cause of sudden cardiac death. So it was a young female who was sustained cardiac arrest. She could not be revived. There were family history of sudden cardiac death, and the options included both Brugada and catecholaminergic polymorphic ventricular tachycardia. They both can cause sudden cardiac death. They both can have family history, but Brugada is more common than CPVT. We'll see Brugada, long QT, and CPVT. These are some of the arrhythmias presenting with sudden cardiac death. So in Brugada, it is ST elevation, curved or saddle-shaped ST elevation, and SCN5A mutation, just like in long QT. In long QT, the QT interval is prolonged, and in CPVT, there is wide complex QRS complexes with ventricular rate of 200 to 300. In this question, no mention of the ECG finding was there. So there is calcium channel rhinodin-receptor defect in CPVT. Other question, one scenario was the patient on chemotherapy. During chemotherapy, the patient is having chest pain which is radiating to left arm, but there are no ECG changes, and there were similar episodes during the previous chemo sessions as well. And the options included both anxiety, coronary artery spasm, or MI. MI could be ruled out, but I think it was coronary artery spasm. Then another question which was easy but a bit crooked, and I made a mistake there. So if you have some straightforward easy question which you are jumping to pick the answer, just hold your horses, read the question, reread the question, and then think whether that is the right answer, because this time it was SPT in asthmatic and I didn't even see the patient was asthmatic. So I made a mistake. So in asthmatic, you have to avoid adenosine and give verapamil. Then another question on WPW. Actually, there were two questions on that. So one was, what is the kind of arrhythmia seen in WPW? Options included AV nodal tachycardia and AV nodal re-entrant tachycardia. So it's actually AV nodal re-entrant tachycardia in WPW. Another question where the ECG finding is described, like there is short PR, double stroke in QRS. It is indicating which kind of arrhythmia. Again, WPW was not in the option, it is AV nodal re-entrant tachycardia. So that is the answer. On cholesterol emboli also, there were two questions. One scenario was patient post-PCI presented with cold leg, femoral artery bruit. What is the diagnosis? Another scenario I don't remember, but it was on cholesterol emboli. Another on straightforward fact-based question, most common cause of coarctation of aorta, it is bicuspid aortic valve. Then HOCM, what is indicating sudden death in HOCM? What the prognostic indicator? It is thickness of septal wall. To be precise, more than 3 centimeter is defined as bad prognosis. Some other questions on cardiology was on SAT2 DS2 VAS score. Like they asked which of the following had high score, and the option included previous TIA, age of the patient which was not less than 65, diabetes, hypertension. But you can see comorbidities like diabetes, hypertension has only one score. Congestive heart failure, age less 65 to 74 again has only one score. But previous stroke, transient ischemic attack has 2 score, 75 and older has 2 score. Okay, so TIA, previous TIA was the answer. Next, patient on coronary artery calcification, already taking beta blocker. What is the additional treatment that you have to give? So in a cardiac failure patient, you have to give AC inhibitor. So that is the concept there. Next, a patient with sinus brady, JVP is elevated, chest is clear. What is the vessel involved? It's RCA. In sinus brady, think of RCA. Posterior MI, think of RCA. But posterior MI, if they don't give RCA in the option and give circumflex, you have to choose circumflex, because in patients where RCA is not supplying posterior wall, circumflex is supplying. Then another question, what is the indicator of LV dysfunction? It is S4. Then another scenario where the patient is having infective endocarditis. There was a drug abuser. There is skin abscess as well. What is the likely organism? So in overall, most common cause of infective endocarditis, also in drug abuser, it's Staph aureus. In prosthetic valve, it's epidermidis. In teeth extraction and tooth infection and all, it's viridins. And in associated with colon cancer is Gallolyticus or bovis, Streptococcus bovis. Then few of the drug-related question: coronary artery stenosis and amaurosis frigax in a patient. That means they have a high CHA2DS2 score. They have to be started on anticoagulant. The answer is warfarin. What is the management? They asked. It's warfarin. What is the mechanism of action of nicoranthal? It's coronary artery dilatation. Then a patient post-cardioversion, patient with AF, what is the drug that you have to give? It's amiodarone. And the question where there were multiple drugs already in a patient, what the ECG showed widespread de-inversion. What is the likely drug? I don't know the answer, but the option included clonazepam. So that was cardiology. Coming to respiratory medicine. In pneumonia, there were a few questions. Some were straightforward. One on curve 65 score. The patient was alert, so no confusion. Urea was more than 7. Respiratory rate was normal. BP was stable. And the age was less than 65. So it scores 1. What is the management? So you have to admit in a ward, start on antibiotics. Then another question which is straightforward. The patient is having pneumonia, found to be Moraxella catarrhalis. What is the management? Another scenario of mycoplasma pneumonia, like pneumonia, cold AIHA, Raynaud's. What is the diagnosis? It is mycoplasma pneumonia. Another where there is community acquired pneumonia, but they're not responding to antibiotics even after 4 days of antibiotic. And it was a right lower zone pneumonia, I guess. And 4 days later also, X-ray showed the same patch. What is the next line management? Is it CT, thorax, or bronchoscopy or sputum culture? I think it was to rule out obstruction, like in a carcinoma case and all. It can persist, right? So it was to rule out obstruction, so most likely it would be CT. That was my line of thinking. If you know the answer, comment down below. Then in a patient post LRTI, presenting with muscle weakness, what is the antibody associated? So there are many questions coming with antibody associated in respiratory medicine, rheumatology. You have to somehow understand and by heart all those. So in this, it was anti-GAD. Other options included anti-GD1, acetylcholine receptor antibody. Among pulmonary function tests, there is a question on GPS. What is the indicator of pulmonary function in GPS? It is vital capacity. Then on occupational asthma, what is the diagnosis? It is serial peak flow measurement. There is 3-month history of progressive breathing difficulty. ABG showing low VO2. Respiratory alkalosis, but respiratory rate is normal. What is the diagnosis? Options included fibrosing alveolitis, hyperventilation, foreign body. But foreign body is unlikely to present for 3 months. Again, hyperventilation is ruled out because respiratory rate is normal. So I thought it was fibrosing alveolitis. Pulmonary embolism, what is the indication for thrombolysis in a patient with pulmonary embolism but stable? So options included RPPB, right heart failure, and some other options. I don't know. I've checked some of the websites to see if there is some indications for thrombolysis. If you know the answer, comment down below. What is the indication for thrombolysis in a stable patient with pulmonary embolism? Next question, pneumothorax. What is the one activity that the patient has to avoid for lifelong? It is scuba diving. In a patient with spontaneous pneumothorax, avoid scuba diving lifelong. What is the likely cause of increased likelihood of ARDS in pregnancy? Options included increased pulmonary capillary permeability. Scenario on obstructive sleep apnea. What is the drug that can some symptomatic improvement in the patient? It is modafinil. Then surfactant production with cellulose involved. It's type 2 pneumocyte. And another question which I didn't expect, that was on alpha 1 antitrypsin. So we have studied alpha 1 antitrypsin deficiency versus emphysema. And there was some question which I had also seen, what is the severest form of the alpha 1 antitrypsin deficiency? It is ZZ type. But the question was, what is the function of alpha 1 antitrypsin deficiency? And the options included production of surfactant molecule. But the answer was inhibit neutrophil elastase. That is the function of alpha 1 antitrypsin, and that is why in its deficiency we are having emphysema. Then another question, I don't remember if it was to diagnose squamous cell carcinoma or they asked what is the cause of hypercalcemia in squamous cell carcinoma. That is PTHRP. But the scenario one, lung cancer with hypercalcemia, that is squamous cell carcinoma, and the hormone related to that is PTHRP, parath hormone related peptide, and it's a paraneoplastic syndrome. Another scenario, ABG is given, methemoglobinemia like picture, patient is already on dapsone. So what is the diagnosis? Methemoglobinemia. Another where there is rectal nasal polyp. Polypectomy was done 5 times previously. There is rectal nasal blockade. What is the cell involved? So it seemed like a cystic fibrosis kind of picture. Cell involved is neutrophil. In a patient with pleural effusion and proximal muscle weakness, what is the diagnosis? It is polymyositis. Neurology. In meningitis, there were 2 questions. On TB meningitis, the patient is started on HRZD, which additional drug would you consider adding? So in TB meningitis, you have to add steroid. So the option included dexamethasone. What is the treatment of listeria? Like a patient is having meningitis, empirically started on ceftriaxone, but CSF culture proved to be listeria meningitis. So what is the next line of management? That is to stop ceftriaxone, start amoxicillin. You have to suspect listeria in a patient who is elderly immunocompromised. On cranial nerve, one question on facial nerve palsy. What is the site of lesion? Stapedius, nerve to stapedius is involved. There is hyperacusis. There is loss of taste in the anterior 2/3 of the tongue. Okay. What is the site of lesion? So it was points. It was an element kind of picture. Half of face is involved. So, but the other options include the facial canal. So it was a bit confusing, but I think it's points. In spinal cord, we question on brown sweat cord. Like the patient after traumatic injury had hemisection of cord. What is the likely finding in the examination? So it is contralateral loss of pain and temperature sensation. So with hemisection of cord, only pain and temperature is crossing at the level of spinal cord or 2 or 3 levels above. But touch and vibration, that is dorsal column, is crossing only at the medulla, and motor sensation has already crossed at the perimeral decussation. So that is also ipsilateral. So ipsilateral motor loss or wasting, ipsilateral touch and vibration, and contralateral pain and temperature. question, I think two questions were there on anterior spinal artery occlusion, like spinothalamic tract is involved, motor tract is involved, but dorsal column is spared. So what is the likely diagnosis? It is anterior spinal artery occlusion. It is sudden also. So it is a vascular phenomenon. Then another scenario which I don't remember completely, but option included thoracic meningioma. That was one I commented on. So there are a couple of questions coming from spinal cord. You have to know the spinal cord syndromes. Coming to stroke, on localization of stroke, that again I think is a favorite area. So you have to go through localization of stroke. One was in dominant parietal lesion. What is the likely finding that you expect? That is Dorsman syndrome with acalculia, agraphia, that thing. So that is acalculia. Then in lateral medullary, the scenario of lateral medullary is given. What is the vessel involved? It's pica, posterior inferior cerebral artery. Then a scenario of INO, in internuclear ophthalmoplegia, that is ipsilateral adduction defect with the contralateral abduction is diagnosed. So in that, what is the site of lesion? It is MLF. Then among peripheral neuropathy dermatome, I think this was the one in neurology where there was a ton of question that come up. So you have to know the dermatome, you have to know the nerve supply, you have to know the muscle, everything. Anatomy is important, especially upper limb, lower limb anatomy and the level, sensory level and all is important. Dermatome is important. And they asked on median nerve. They asked about wrist drop, which is posterior trochleus nerve. Asked about foot drop, which is common peroneal nerve. Then sensory loss in the palm, 2.5 up to the middle side of elbow. What is the nerve root involved? C7, C8. Then biceps reflex is lost with lateral side of upper arm lost, sensation lost. So it is C5 root. Biceps is actually C5, C6, but upper arm lateral side is only C5. So it is C5. Then lateral side of foot is sensation is lost along with ankle reflex. Ankle reflex is L5, S1. Lateral side of foot is S1. So it is S1 root. Then plantar flexion, which is the muscle involved. Then for peripheral neuropathy, what is the treatment of choice? Option included carbapenem. Other questions from neurology. One was on idiopathic intracranial hypertension, a female patient with headache, papilla edema, visual disturbance. What's the diagnosis? Then in Wernicke, along with ataxia and confusion, what is the other finding? Option included ophthalmoparesis. If it is not there in the option, you can choose nystagmus if it is given. Another question on bitemporal quadrant anopia, not hemianopia. What is the site of lesion? It is option included suprasellar mass. For some reason, I chose that. Again, options had pituitary mass, sellar mass, and so many other things. Then cavernous sinus thrombosis. Facial vein is anastomosing with which vein so that it predisposed to cavernous sinus thrombosis. A direct anatomy question. Then a patient post-hypophycectomy, a cranial diabetes insipidus-like picture with polyuria polytipsia. What is the investigation? That is water deprivation test. Then a patient, female patient with headache, migraine-like picture. What is the prophylaxis? Then to toxicity. One is alcohol with pupil dilated and all. One is lithium. Then cerebellar signs in a patient. What is the structure that the cerebellum compresses on? The cerebellum is close to fourth ventricle, so it compresses on fourth ventricle when it enlarges. Then Parkinson's and Parkinson plus disorder, you have to know. There were one question on multisystem atrophy and one question on Lewy body dementia. Lewy body dementia, they asked what is the likely finding that makes you think of Lewy body dementia, that is sensitivity to neuroleptics. To endocrinology, on thyroid again, there were a couple of questions. Thyroid cancer associated with MEN2, that is medullary thyroid cancer. Then on TFT, TSH elevated in an asymptomatic male patient, and he has done simply as a part of some insurance coverage or something. So there is no symptom, but TSH is elevated, T3, T4 is normal. What you have to do? which is to recheck after 3 months. Then another TFT picture where TSH is high, T4 is normal. In a patient already on thyroxine, what is the diagnosis? It is non-compliance to drug. Just 2-3 days prior to the testing, they'll comply to the drug and they'll take it early in the morning, empty stomach. Other days they'll forget. So TSH will take time to normalize, but T4 will get normal by the day of testing. So that is why TSH will be high, T3, T4 normal on a patient already on thyroxine. So of non-compliance to the drug. In a patient postpartum, 3 months postpartum, coming with TSH 0.05, there are symptoms of thyrotoxic symptoms as well. But T3, T4 high, is it Graves or postpartum thyroiditis? I don't know the cutoff for postpartum thyroiditis. I think it is Graves. On diabetes, there were a couple of questions. The patient with diabetes, diabetic retinopathy, diabetic kidney disease. What is one thing that you can do to reduce progression of renal impairment? That is strict glycemic control. Then they asked what is glycemic index? That is spike in blood glucose after some food intake. Another question where 5 food items are given. One included 100 gram milk chocolate. Another one is 2 granola toast. Another food item, I didn't even understood which food item it was. But they asked which of the following is likely to cause a higher spike in glucose or which is having high glycemic index. I thought it was milk chocolate, but granola is having higher glycemic index even than milk chocolate. So I don't know other options, so I am not sure of the answer. Another scenario where there is darkening of skin over the nape of neck and axilla, such as acanthosis nigricans. What is the commonest cause of acanthosis nigricans? Is it diabetes, hypothyroidism, obesity? I think it was diabetes. Then embryonal cell used in DNA management. What is the action, or what is it protecting from? Protecting the cell from? Is it acetylation, glycosylation? On the answer, I think it's acetylation. Then on acromegaly, what is the confirmatory test? It is glucose tolerance test. Then there were questions on Turner, short stature female with amenorrhea and no limb abnormality. There were questions on Klinefelter, a male patient already had done breast surgery on one side, coming with gynecomastia on the other side. And then on Kalman, a patient with low FSH, LH, and what symptom will make you think of a diagnosis? So it was anosmia in Kalman. So when we talk of the difference between Kalman and Klinefelter, Klinefelter is primary hypogonadism where the situs testis. Testosterone is decreased but FSH, LH is increased. In Kalman, it's secondary hypogonadism where the site of problem is pituitary or hypothalamus. The testosterone is decreased, FSH, LH is decreased, or there is no change. So that's the difference between Klinefelter and Kalman. There were questions on Conn syndrome, Cushing syndrome. I don't remember the correct scenario. Another tricky question which I felt in investigation, vitamin D was low. Patient is already on calcium. So calcium is high. PTH is also high. Phosphate is low. What is the drug that you have to give out? What is the kind of management? Is it vitamin D replacement or parathyroidectomy? So I didn't know what was the answer. Coming to gastroenterology, in liver cirrhosis, there was some question. A patient on liver cirrhosis with portal hypertension. So there is splenomegaly, ascites, right-sided pleural effusion. Along with that, there is also cardiomegaly and pedal edema. What is the test you have to do? Option included AFP. So I thought it was AFP to rule out hepatocellular carcinoma. Again, a patient with ascites, SBP-like picture. What is the next line of investigation? It is ascitic fluid tapping. In varicose bleeding, what is the line of management? Terlipressin can be used in management of varicose bleeding. Another anatomical straightforward question, esophageal varices drain into which vein? Option had azygous vein, that is the answer. What is the commonest complication of TIPS procedure? Option included encephalopathy, pruritus, and all. For some reason I chose pruritus, but the answer is encephalopathy. That is the commonest complication with TIPS. And other questions in gastroenterology. One question which I felt was a bit confusing or a bit tricky was, like, if you half read the question, you are likely to get it wrong. Gastrin act on which cell to produce HCl? So if you read it like which cell produce gastrin, you would choose G cell because that was in the option. But they asked which cell produce HCl because gastrin is one of the stimulant for production of HCl. So that is parietal cell. And then for H. pylori eradication, what is the test that you do to confirm eradication? It is urea breath test. And achalasia cardia, what is the manometry finding? Options included basal increase in pressure or increase in pressure with swallowing. So I got confused between the two options. So just make sure you know the answer. Achalasia cardia, what is the manometry finding? Then what is the reason for recurrent hypoglycemia and alcoholic? Is it reduction in glucagon or some other reason? IBD, there were two questions. One, female with prolonged diarrhea. They had already ruled out celiac. What is the next line of investigation? So they asked what is there to rule out IBD. So to differentiate from IBD or IBS, there is no passing of blood in stool. So it is not an emergency thing. You just have to rule out IBD. So option included fecal calprotectin. That is to differentiate between IBD and IBS. So in irritable bowel syndrome, fecal calprotectin will be low. In irritable inflammatory bowel disease like ulcerative or Crohn's, it will be high. And there were family history of some Crohn's or ulcerative as well. So they are asking what is the initial first line investigation to rule out or differentiate between the two. Another question, what is the indication of surgery in a patient with ulcerative? So I think it was based on true love and its criteria because the option included anemia, low albumin and all, but the correct value is given in this true love and its criteria. They include stool frequency, pulse, rectal bleeding, hemoglobin, weight loss, temperature, ESR and albumin. Just go through this. I think that option included anemia. That was the answer. It was less than 10.5. Then a question which while doing past test paper also, it's tricky, but since I've done past test, I knew that there was this trick in that. So that is a patient where the scenario is most likely to be celiac disease. Now, investigation showed IgA is low, TTG is also negative. What is the diagnosis? So when IgA is low, TTG can be negative, but that does not rule out celiac disease because TTG is a kind of Ig antibody. So in that case, TTG can become negative, but that does not rule out celiac disease. The diagnosis can still be celiac disease. Then in a GA bleed patient, after primary stabilization, what is the next step? HP was low, platelet was low. It is blood transfusion. Then a scenario on cholestasis of pregnancy. So you have to know what is HELP syndrome, what is cholestasis of pregnancy, all those pregnancy-related liver diseases. Pregnancy-related, I think many questions were there, like post-pregnancy, postpartum thyroiditis, pregnancy-related this cholestasis, pregnancy-related pulmonary this thing, and pregnancy, what is contraindication of pregnancy? That was pulmonary hypertension. So I think pregnancy-related, so many questions were there in that paper. Then hemochromatosis, what is the management? It is venesection. Coming to renal, some questions that I remember. Tuberous sclerosis, what is the likely finding in renal biopsy? It's angiomyolipoma. Then varicella vaccine in transplant patient, what is the timing of vaccine? And the options included 4 weeks prior to the transplant in the recipient or 4 weeks prior to the transplant, both recipient and donor. And I don't think there is requirement in donor. So I think it is pre-procedure, that is 4 weeks prior in recipient. Frank hematuria, what is the next line management? It's cystoscopy to rule out urothelial carcinoma. A proteinuria hematuria patient, what is the next line investigation? It's renal biopsy to identify what is the likely diagnosis. Then HAGMA kind of picture, high anion gap metabolic acidosis kind of picture. Lactate were normal. and sugars were also normal. But decay can happen in a patient with homoglycemia also. So again, the diagnosis diabetic ketoacidosis. And they asked AC inhibitor what is the effect on renin and aldosterone, and the options were different combination of increased renin, low aldosterone. I think it's low aldosterone in increase in renin. Just make sure that you know the answer. What is the effect of renin, AC inhibitor on renin and aldosterone? Another question which I found a bit tricky: trimethoprim. What is the cause of increase in creatinine when they are prescribed trimethoprim? Option included lab error, like some interference with the lab investigation. I thought that was the answer, but it is competitive inhibitor of tubular secretion of creatine. That's why trimethoprim is causing an increase in creatine. Then site of production of active form of vitamin D. Direct question: what is the site? It is kidney. Then a scenario on arthritis renovascular disease, acute interstitial nephritis. The culprit drug was given. There is eosinophilia, rising creatinine. What is the diagnosis? It's acute interstitial nephritis. Then scenario on renal tubular acidosis. I don't remember the correct scenario. Then a tricky question where a young patient, female patient, there is a history of anxiety. There is low potassium. What is the likely diagnosis? Other investigations are all given. Options included both gentleman as well as diuretic abuse. So in a patient already with the anxiety disorder, I don't know, maybe diuretic abuse, but the option had gentleman as well. Coming to infectious, among bacterial infection, a question on food infection. Patient had consumed some seafood and all. Within 4 hours started vomiting. What is the likely diagnosis? Is it staphylococcal toxin or scomprotoxin? Seafood scomprotoxin could be a possibility, but with 4 hour such short incubation period is for staph. So I chose staph. In human bite, what is the management? It's augmentin for animal bite, so it is augmentin. Then a scenario where the patient is having some infection, culture showed it's GPC in cluster, so it is staph. Then viral infections, question on measles. Then what is the maximum infectivity? Is it varicella or H influenza? Like a patient, so many patients are in the isolation ward, which is the patient in high need of isolation from other patients, or which is the one having high infectivity? Is it for varicella or H influenza? I thought like H influenza is a droplet infection, so more infectivity than varicella. But the options had both. Then among parasitic infections, anaerobius causing pinworm. So pinworm infection, what is the causative organism? It's anaerobius. In Lyme disease, history of tick bite with annular lesion. It's Lyme disease. Option also included annuloma granulare, but I think it's Lyme disease. And what is the management of Trichomonas vaginalis? It's metrogen. Among STD, molluscum contagiosum in HIV patient. Then a question on trypanema, I don't remember the scenario. Then a question widespread rash and widespread lymphadenopathy. Option included keratoderma, blepharoragic. Then fluid of choice in septic patient. Asymptomatic bacteriuria in pregnancy. What is the next line management? It's to start antibiotic. Then ulcer in diabetic patient on the back of leg. What is the management? Coming to pharmacology, among drug interaction, question on statin clarithromycin. Patient on statin started with clarithromycin, presented with hematuria, CKMB was high. So what is the diagnosis? It's rhabdomyolysis. Because clarithromycin is an enzyme inhibitor, so it increases the level of statin. That causes rhabdomyolysis. On mechanism of action, there were a couple of questions on clopidogrel. What is the mechanism of action? It acts on ADP receptor. Dabigatran, direct thrombin inhibitor. Bevacizumab, anti-VEGF. Empagliflozin, reduced reabsorption of glucose from the kidneys. Naproxen, it is an NSAID. Imatinib, tyrosine kinase inhibitor. Baclofen on GABA, co-steroid GnRH agonist. And site of action of both entopimide and spironolactone were asked. Spironolactone is a potassium-sparing diuretic, so you can remember the site of action of diuretic as cold P. So it is in the order of site of action. So C for carbonic anhydrase, which is acting on PCT. O for osmotic diuretic on the loop of Henle. L for loop diuretic on the ascending limb of loop of Henle. T for thiazide diuretic, which is acting on the DCT. P for potassium sparing diuretic, which is acting on the distal part of TCT. So indapamide, it's a thiazide diuretic acting on TCT, spironolactone on distal part of TCT. Side effect question: a patient started on HRZD for TB. What is the drug causing peripheral neuropathy? It is isoniazid. What is the side effect of ciprofloxacin? Tendinopathy. A patient on bisphosphonate had dental extraction. What is he predisposed to? It's osteonecrosis of jaw, especially in a patient who had dental extraction in already bisphosphonate. Which of the drug is likely to cause increase in glucose? It includes indapamide, thiazide diuretic. It is non-culprit for hyperglycemia, so that is the answer. Anaphylaxis. Like reaction, what is the next line of management or first line of management? It's adrenal. Then warfarin, what is the cytochrome involved? Isoniazid to toxic metabolite, which is enzyme involved. Option include an acetyltransferase, that is the answer. Another scenario which was a bit tricky and a long scenario, like a patient who had ESH with paracetamol, diazepam, and some other drug. They are brought and started on NAC for paracetamol toxicity. They have an allergy-like reaction. 30 minutes post stopping NAC, they return back to normal. So it is NAC overdose or NAC, allergic reaction to NAC or disulfiram-like reaction. I don't know the answer, but this was the scenario. Coming to hematology and oncology, there were a couple of questions on complication of blood transfusion and other scenarios. Complication of blood transfusion, they asked about TACO. Like a patient post-transfusion, they had elevated JVP, bilateral B lines. What is the diagnosis? So you have to know what is the difference between TACO and TRALI. Transfusion associated cardiac overload and transfusion associated liver injury. Lung injury. Then what transfusion can cause increased risk of bacterial contamination? It is with platelet transfusion because platelet is stored at room temperature. Hodgkin's lymphoma is associated with which cell? It is Reed-Sternberg cell. Polycythemia, what is the cause of hyperkalemia? It's membranolysis. What is the origin of uric acid in generalized syndrome? I don't remember the option, but that was the question. Then another question from hematology, ITP. And another scenario where a patient started on chemo for AML. They come with some infection and they're not responding to antibiotics. So what is the likely cause? Is it CMV or fungal? That's what they asked. In APLA, what is antibody? It's anticardiolipin. Patient with bilateral tibial swelling, what is the investigation of choice? Is it X-ray or some other option? I don't remember what the other options were. In palliative medicine, some questions like Barthel index, what is it indicating? It's indicating activities of daily living. In Parkinson patient with end-stage rigidity, what is the management? Is it oxycodone or morphine? Then direct question, according to morphine conversion, what is the dose conversion? So you have to divide the codeine dose divided by 10 to get the morphine dose. You have to give the answer of morphine. They are going to give morphine as a BD dose, but you have to give what is the total daily dose. So it was a bit mathematical and a bit confusing question. Anyway, you have to divide the total dose of codeine for the day divided by 10. That will be the total dose of morphine for the day. Then if you are giving it 2 times a day, you have to divide by 2. But they are asking the total daily dose of morphine, so you have to divide the total daily dose of codeine by 10. Coming to rheumatology, in rheumatology the questions were from mainly osteoarthritis, ankylosing spondylitis, rheumatoid arthritis, like that. So from OA there were 2 questions. One, X-ray picture of OA is given, like joint space narrowing, osteophyte formation. they asked what is the most important X-ray feature among the thing. Is it joint space narrowing or osteophyte formation? Then another where the patient is having OA-like presentation, and X-ray features of OA is also given. They asked what is the diagnosis. So it is osteoarthritis. Next question was on ankylosing spondylitis. What is the eye finding? It's acute anterior uveitis. Like a patient is having ankylosing spondylitis presented with acute painful eye. What is the diagnosis? It's acute anterior uveitis. And what is the cause of dysphagia in CREST syndrome? So in CREST syndrome, we know there is calcinosis, Raynaud's syndrome, esophageal dysfunction or dysmotility, sclerodactyly, which is thickening of finger, skin over the finger, and telangiectasia. They asked what is the cause of dysphagia. So it is actually esophageal reflux. We only study what is that there is esophageal dysmotility, but what kind of a dysmotility is there? It is reflux. Then they asked, like there is a patient who is having scleroderma, then they are presenting with diarrhea. So that is indicating bacterial overgrowth syndrome, which is associated with scleroderma. Then they asked antibody, which is anti-RNP antibody. Then sickle cell crisis was there. The presentation of sickle cell crisis, it was a hemolytic crisis. So you have to know the hemolytic crisis, what is vaso-occlusive crisis, what is acute chest syndrome crisis and all. You have to know that. Or sequestration crisis. Then rheumatoid dry eye, what is that eye finding? It is keratoconjunctivitis sicca. Then a patient using some tools, vibratory tools. What is the kind of injury? It's a mechanical repetitive injury. Then a patient with rash arthritis, what is the test that you'll do? It was Coming to ophthalmology, there were a question where a patient, again I told there were many questions on pregnancy. Pregnancy with sudden visual disturbance, there is floaters. What is the kind of etiology or what is the pathology that is happening there? Options included vitreous detachment and anterior uveitis or some other options. I think it was vitreous detachment. I don't know. If you know the answer, again, comment down below. Then neurofibromatosis, what is the eye finding? It is glioma, optic glioma. Then swelling on one side of the eye, on the eyelid, which is the causative organism. Options included Pseudomonas staphylococcus. I don't know what they are indicating with that. Then vision loss in one half of the field of eye. What is the investigation? It is retinal angiography because it is a vascular phenomenon. From dermatology, they asked what is the Ig involved in dermatitis herpetiformis. It is IgA. Then erythema nodosum, what is the usual fate? They gave a scenario of erythematous rash over the shin, which is erythema nodosum. What is the usual fate? Is it resolution or progression to sarcoidosis? So it is resolution, spontaneous resolution. Then over the cheek of a female, there is vascular lesion over erythematous space. What is the cause? And there were multiple episodes in the previous couple of months. So what is the diagnosis? Is it herpes zoster or herpes simplex or I don't know other options. And I don't remember if it included acne. Then a patient with recurrent seborrheic dermatitis, what is the patient to be tested for? It's HIV. Then some skin manifestation of zinc deficiency, but there were other options like selenium, manganese and all. I think it was zinc, especially coming with skin manifestation. Then scarring alopecia with psoriasis. From geriatry, there were two, three questions. One, elderly refusing to visit grandkids. There is loss of memory. So is it dementia or depression? It is dementia or depression because there is no mention of, there is loss of interest of doing usual activity like visiting grandkids. Is having loss of memory as well. So I don't know if it is dementia or depression. Then a patient who is bedridden. He has to be taken from one bed to the other, so he can't move any of his limb. And they are coming with hypothermia. So what is the mechanism? It is loss of shivering. Then cause of GI hemorrhage. In elderly patient, a scenario of GI hemorrhage, it is usually diverticular. In psychiatry, they asked about PTSD, like a patient who had lost his wife. It was an accident, and many months later, he could still recall and see that visual image of his wife jumping from a mountain or something. So it was post-traumatic stress disorder. Then a patient is anxious about he or she, I don't remember, having some certain illness. That is anxiety illness syndrome. Illness anxiety syndrome. Then a patient having a young female who is having multiple episodes of loss of consciousness, which is prolonged, like 45 minutes. And there is no post-ictal state, and she could be helped to sit down. That means there is no complete loss of tone or jerky movements or anything, and there is some stress event like separation of mother and father, I think. So one of the option included cataplexy. Then a patient started on fluoxetine for depression. After 4 weeks, there is no improvement. What is the next line? Management. On statistics, there was one question on t-test. What is the test that you use to compare the means of two groups? Then to calculate the sensitivity of a test. To calculate positive predictive value. Then what is power of a study? They asked. Then other questions from clinical sciences. One question was, a patient is afraid that he is getting Becker muscular dystrophy from his father. So what is the investigation that you have to do to rule out Becker muscular dystrophy in that patient? So you need not do any investigation in that patient because it's an X-linked recessive. There is no way that the son is acquiring the disease from his father. So that is a trick in that question. Then Hayflick limit is attributing to what among the following? So it is telomere. Then in APML, acute promyelocytic leukemia, what is the defect? It's a protein fusion defect. PML-RARA fusion. And so you have to know from oncology what is the gene defect, especially of Burkitt. You have to know of APML, you have to know of CML, what is the prognostic indicators. You have to know what is the cancers associated with P53, BRCA1, because there were questions on that. The family history of sarcoma, breast and lymphoma, it's P53. Family history of breast, ovary, colon, it can be BRCA1. Breast cancer and follow-up, ALP was raised. So what is the blood test you have to do to rule out metastasis? So it is CA15-3. Ovarian mass, renal fluid collection with ascites, what is the marker? CA125 for ovarian mass. MHC class 2 attached to what CD? CD4. You can remember MHC 1 to CD8 and 2 to CD4. A multiple of 8 has to come. 1 into 8 is 8. 2 into 4 is 8. HLA function is antigen presentation. And there was a question, DNA is able to identify many organisms. What is the character or attribute of DNA that is helping DNA to identify many organisms? Is it mosaicism or microsatellite instability? Then lattice fruit syndrome. One question, that the patient is known to have allergy to latex. What fruit can precipitate allergy in this patient? So that is latex fruit syndrome. So that is banana. Banana is associated with allergic response in a patient who is known to have latex allergy. So that was pretty much the recall. I've divided that into topic wise and added all the questions that I could gather from my own memory and from here and there, from Reddit, from WhatsApp groups and everywhere. So I think that was pretty much the paper.